The following program is brought to you by the Center for Educational Outreach at Baylor College of Medicine.
Good evening, everyone. And it's great to see all of you in this much more relaxed setting than we usually see everybody in the clinic, kind of worrying about what kind of blood draws your kids are going to get. So it's really fun, and it's actually been so much fun just to stand outside and see who walks in. It's like, I don't want to say a high school reunion because some of us may be a little queasy about high school reunions, but it's sort of like this gathering of long-lost friends that we haven't seen in a long time. So thank you all for being here, and thank you all for having us speak to you. And I also want to second Dr. Bacino's last slide. I forgot to thank Susan and the Down Syndrome Association and the Texas Department of Health last time. So I also want to express my gratitude to everybody as well. What I wanted to talk to you about are some topics that are important, and I think that we think about, that are in the back of our minds all the time, and that are sort of interest to me, behavior, and then rarities that are associated with behavior, and also sexuality. I hate to say that's a topic of interest of mine necessarily, but it's a topic that I really want to educate everybody about so that we can empower these kids to go out there and to be as independent and knowledgeable as possible. Now, this first slide just shows a picture of a series of books, mainly dealing with behavior issues. One of the books is Hands Are Not for Hitting. One of the other books is Diapers Are Not Forever. Feet Are Not for Kicking. So if you just kind of Google behavior issues, you'll actually find this, and I think you can order the series. Germs Are Not for Sharing. So just lots of different wonderful books that are helpful, targeting certain issues that a lot of parents may face as your children go through different ages and stages. Now, whenever we talk about behavior, there's this whole concept of nature versus nurture, and I know a lot of you have heard this and read about it before. Basically, there's a school of thought where it's all sort of inherent. Everybody is sort of made a certain way, and that's how you're going to act. There's another school of thought at some point that said, well, it's when you put a person into a certain surrounding, they are going to learn how to behave a certain way. I think those of us now that work with children and that work in behavioral fields really see that it's not just one or the other, but everything sort of interrelates. First of all, we have personality, or what we like to call temperament. So that's sort of our innate ability to respond to our environment. And then that affects sort of how we think, and how we think, and sort of how our mind works and where our minds are functioning. And then, of course, there's genetics. So we're all sort of made a certain way. There's this blueprint of how we're built. And that gets affected by our surroundings or our environment. Sometimes, it depends on sort of what setup we have in our home. That kind of influences the person as a whole, and then influences our personality or temperament, and it just keeps going in this cycle. So everything plays together very nicely, and I didn't really have a way to make it a puzzle, but it's sort of a puzzle that can fit together and cannot fit together, so it's a little hard to sort of say that it's one or the other. When we talk about behavior, the way I wanted to categorize this is acceptable or common, things that are not common or things that are not common, things that are acceptable or okay, and things that are not acceptable or are not okay. Now, when we talk about temperament, like I said, temperament is really our internal ability to respond to what's around us. Now, when parents of children who have Down syndrome were interviewed about what they felt their child was like or what kind of personality type they fit, and you all can sort of attest to some of these too. A lot of parents describe their child as being their easiest child, being very affectionate, and we see quite a bit of that as well, being very friendly, being stubborn, and I think I see some heads nodding with that one, and of course being active. So these are all very common characteristics, and it doesn't necessarily classify the whole group of children, because everybody sort of has a different piece of this, and every child is very unique. Now, when we think about different components of temperament, that what kind of makes us who we are, there are all these different factors that come into play. So when we think about this, we think about how active we are, our activity level. Some folks are really, really active. Some people can exercise every day, can run 10 miles at a time. They can go into a room and reorganize everything and just have to be constantly doing something. Then there's also what we call rhythmicity, and this is sort of how regulated we are. So some people like to be on a schedule. They like to know what to expect. They get up in the morning. They have this routine. You drink a cup of coffee, you read the paper. There's also what we call approach withdrawal. So this is sort of how well people interact in a new situation, especially with new people around. And then what we call threshold. This is really more like what we call sensory threshold. So it's how you adapt to certain sensory aspects of your environment. So if you, for example, if I go to Central Market, I get really overstimulated. It's loud, it's kind of chaotic, and there's so much happening at one time. And I feel like all these shopping carts are coming at me. So I get a little nervous, and I just kind of take as many shortcuts as possible and try to leave. And then also we have mood. So some kids are, sometimes you're happy, sometimes you're sad, and sometimes you're varying degrees of that and varying extremes of it. Distractibility is how we respond to different things that happen and how you get sidetracked. If someone's child might make a noise, I might get sidetracked and see what's going on. And then, of course, persistence. And this is sort of how badly somebody wants something, or how much a child might really, really sort of beg for you to do something they want. And we'll talk a little bit about how to manage that in a minute. What I wanted to also touch on are things that are not common, are things that are rare that we find in behavior. So about 7 to 10% of children who have Down syndrome can also actually meet criteria for autism. Basically, the way we classify autism is kids will typically have a delay in their speech. Along with that, they also have difficulty in social behavior, or typical social behavior. They start to do certain things over and over. A lot of times kids will start to have certain movements that they repeat. Some kids may flap their hands. Some kids may rock back and forth. A lot of times we see a lot of these behaviors before the age of 3. We also, in a small group of kids, see a loss of skills at one point. We hear from parents that they used to talk and then they stopped talking very suddenly. Now, when we look at children who have Down syndrome and autism and compare them to their peers with Down syndrome who don't have autism, a lot of times the children who have the autism tend to have lower level of functioning, so they may not be talking as much at the same age. And also, a small group of children can have seizures. Typically, we see the seizure disorders usually get a little bit better with age. Many of them respond to treatment, and some kids actually wind up getting off of treatment. And we've seen children that eventually do very well and get off of treatment actually learn how to talk and learn how to be very independent. So they can do pretty well. I also want to talk a little bit about oppositional defiant disorder. Children who have oppositional defiant disorder may also have something else like ADHD or an anxiety disorder. Typically we see aggressive behavior. Now this kind of behavior is usually in response to setting a limit or setting a rule. For example, if you take your child to the store and they want a certain toy and you don't want to buy it for them, then they're on the floor screaming and rolling around and wreaking havoc. A lot of this behavior is very attention-seeking, and we see it all the time in our clinic when we try to get kids to do things that they don't really want to do, if we're trying to get them to tell us what a letter is or identify numbers. We may not realize it, but we may be actually rewarding this behavior. So if your child goes to the store with you and they're crying and screaming, and then you go ahead and buy them the toy anyway, we don't realize it. We just want our child to stop crying, especially because you're in public and you don't want people to call the authorities. But you really are reinforcing the behavior, and so that kind of clicks off a light bulb in your child's brain. Oh, if I do this every time we go to Target, I'm going to get anything I want. So it's really important to sort of be at least 2 steps ahead of your child every time, and that is very hard because We may not realize it, but our kids, to some degree, are a little bit smarter than we are sometimes. We also see a lot of oppositional difficulties in kids who have more learning problems. So when you're coming at them with some kind of homework task or any other kind of task that they perceive as difficult for them, they become a little more oppositional. It kind of starts off with, I'm tired, and then it's, I don't want to, and then they might throw the book. So it sort of escalates a little bit. So you want to kind of catch it before it escalates into something physical. And then everybody has heard of ADHD. I think it's sort of a diagnosis to me that I have a very hard time making in young children, especially young children who may not be necessarily acting like their actual age. So we may have a 5-year-old that comes and sees us in clinic, but if their language level is like a 2-year-old and they're really active and they're kind of getting into things, that's what I expect to see a lot of times with 2-year-olds. They tend to be really curious. They tend to explore their environment without really having a specific goal. But when we clinically make this diagnosis, we look for kids that have a difficult time paying attention to learning or paying attention to their parents' directions. A lot of times they can be impulsive. They do things without thinking. Sometimes they might grab a toy from somebody. Sometimes they might actually punch their brother or sister without even understanding there's a consequence associated. A lot of times these kids can be very active. Now when they come to the office, I know who has ADHD because these kids are usually literally running around, climbing all over the place, grabbing the stethoscope, grabbing everything. So if I don't see that, then I typically don't make the diagnosis of ADHD. So just going on to the next point, really we have to see these features in multiple settings. Typically what we do is we get information from you as a parent and your child's teacher. And that way we can sort of put it together and see where the puzzle pieces fit. Now some of these behaviors may be typical in children before the age of 3. And just like I said, if you have a 2-year-old, many times they're exploring their environment, they're kind of getting into everything, they're very curious. So it's really hard for me to make a diagnosis of ADHD in any child who is less than the age of 6. I also like to make sure that there's no health-related reason for hyperactivity or impulsivity. Dr. Oppositional spoke very eloquently about obstructive sleep apnea. Now, if you think about if you haven't gotten enough sleep and you're sort of not with your game the next day, it's going to be really hard for you to focus, it's going to be really hard for you to pay attention, and it's going to be really hard for you to remember things. So the same thing happens with children, except probably times 100. If they haven't gotten adequate sleep the night before, when they're trying to go to school and they're being asked to learn and remember and listen and follow directions, it is really, really difficult for them. So we like to make sure that that's not an issue. And also, like Dr. Oppositional said, we check for thyroid problems every year. Although it's kind of rare in kids who have Down syndrome, sometimes we can see too much thyroid or hyperthyroid, and those kids tend to be a little more active. Now, how you help kids manage a lot of these behavior issues if you see them. What I like to know is what actually causes this type of behavior to occur. So we call that the antecedent. And those of you that have been to school meetings and these ARD meetings, a lot of times if there's a behavior specialist involved, they will talk about these things, but they talk about the ABCs of behavior. So the antecedent is the A. So what causes this reaction to happen? And then you have the behavior. So what is it? So for example, if I were to pick up this computer and throw it at somebody and hurt them, what caused me to do that? What was it that made me pick up the computer and throw it? And then, of course, the C is a consequence or the result of that behavior. So hopefully, I would have a consequence. Somebody would have called the police and maybe charged me with assault at that point. Basically, what you want to do when you look at these different components is you want to see how to change the negative behavior to be something a little more positive. Basically, the best way to do that, and what I found is something that helps, is something that's really concrete. So a lot of kids respond really, really well to things like stickers, smiley faces, stars. So I always suggest doing a chart. And this is a really good way to reinforce learning as well. So every time your child does something you want, so it's important to have goals that are really reasonable. You don't want to tell your child, okay, if you have to get up at 6 a.m. every day throughout the school year, because that's 9 months of the year. And really, that's such a long-term goal that it's going to be really ineffective to make it that way. You want to pick small goals for a small period of time. So, for example, you want to make sure your child puts his or her plate by the sink every single time. Every single time your child puts his or her plate by the sink, he or she gets a star or a happy face. When your child accumulates about 5 or 6 of those happy faces or stars, and you can let your child count, then they get a more tangible reward, or something like being able to spend more time watching TV, or being able to go to the store and pick out something they like, or eat something they like, something like that. But every time your child does what you would like for them to do, you have to reward them. So you can't skip out on rewarding your child, because then the whole system sort of backfires. So it's really important. And I always say consistency is probably the most important. A lot of children live in 2 different households or go visit other family members. So it's really, really, really important that that child has as consistent an environment everywhere he or she goes. Now, you can use medicines, and when we use medicine, we're really trying to target specific behavior problems. So, for example, if there are kids that are overly aggressive to the point that it's really impacting how that child functions in a school setting or at a home setting, or actually in both settings, then we would think about medicating to target that aggressive behavior. Same for something like ADHD. If we see a child that's having problems focusing and with hyperactivity in multiple settings to a point that that child is not doing his or her best, then yes, we would think about medication. But again, for me, it's pretty rare that I will actually put a child on medication. And I'll have to say that the kids that have not taken medicine have been probably more successful than kids who do take medicine. Some other ways to help. A lot of you have heard of applied behavior analysis, or ABA. ABA is really geared towards children who have autism and have had specific behavior issues. However, if you take the principles of ABA, it's basically based on what we call reinforcement. So if a child, the way I've seen it done is if a child properly identifies a picture or any type of verbal type of stimulus, then they get a reward, like a good job or a high five. Every time they get that high five, they're going to want to please you even more. So the whole concept or the philosophy can really work with any child, because they really do respond very well to that positive reinforcement. And again, just like we said, it's really important to find the cause of behavior issues. Now, a lot of times, kids may have something that changes either at home or at school. Sometimes there's a new teacher or teacher's aide that maybe doesn't click very well with the child. And yes, there can be personality conflicts between adults and children. Not all adults really are able to connect with the child as well as other adults are. And also changes in routine. We get a lot of calls in the summertime because there really is no routine. So we get a lot of these, I think my child has ADHD calls in the summer. And it's probably because they're getting a little overstimulated playing the Wii a lot, or playing the PlayStation a lot, or watching cartoons all day. So if there's a change, it's really important, even when you're relaxed, to try to keep things as much of a routine as possible. And as we mentioned before, it's important to make sure that children have a very similar schedule and is in all their comfortable settings. Now, whenever we're looking out for the best interests of children, not only is it, parents are probably the captains of the team, but then there are doctors, there are nurses, there are therapists, there are social workers, there are so many people who are involved. And it's really, really important that for all of us that we keep those lines of communication open so that we all are on the same page. I can't tell you how many times I have actually contacted a school and gotten a completely different story from what the family felt was happening. So when we sort of bridged that gap a little bit, it was really, really helpful, and it was really best for the child. Now, as adults, it's really important that we remember that we were probably the best role models for our children, especially as parents. They do look up to their parents more than anybody. So it's important that however you want your child to behave is how you behave around them. And again, you want to communicate rules. So whenever children come to the clinic and maybe do something that's a little unacceptable, you have to get at their level and explain to them, listen, we do not throw toys, or we do not hit our mother. And getting at eye level seems to really work. It's really important when you identify an area that's difficult where a child is struggling. For a lot of kids that we see, communication and language can be a bit of a struggle. You want to make sure that you make it easy for them to communicate with you. So a lot of times you can use sign language, or you can say use your words and give them a little bit of a prompt. And the best way is really focusing on good behavior and good social interactions. You make everything fun and everything educational for your child. Even going to the store or going to the grocery store can really be a fun experience. You can count, you can look at the produce, you can identify colors, you can identify shapes and count, and it really becomes a wonderful interactive experience for you and your child. And if there are any health issues, it's really important to treat those. And really, I think for all of us, we have a very low threshold for treating medical issues. Now, as kids get older, I think a mission of mine is really to teach our kids how to be empowered. And it comes from we as parents, as physicians, as teachers being empowered as well. It's really okay and it's really encouraged for all children with any type of special need to be friends with typical children. As they grow up and get older and sort of move into those teenage years and the young adult years, it's really important to just support them and guide them, but not really hover over them, because they are going to develop their own personality, and it's important to let them do that. Again, for me, I think it's important that we really work on changing the perception of individuals with special needs in the public. I think there's always been this stigma, and honestly, after doing this for the many years I have, I don't understand the stigma. I think, no matter how many chromosomes your child has, no matter what color you are, what you look like, everybody likes doing the same things. Like, I'm Indian, but I like to eat pizza and enchiladas just as much as anybody. I don't just eat Indian food. So I think our kids really enjoy doing a lot of the same things that their peers like to do, regardless. Gosh knows how many times I've heard about High School Musical in the last couple of years. And also, it's really important to get kids into the community. We have a wonderful wealth of resources for individuals with special needs in the Houston community, and it's really important that kids get out there and not just socialize with children who are like them, but with everybody, because it's important for kids to be exposed to their peers and for their peers to be exposed to them, because it's an educational experience for all of us. And also, it's really important to encourage as much independence as possible. Now, with that, I want to kind of shift over into what's acceptable when thinking about romantic relationships. And I think a lot of you have read in CNN.com about Sujit and Catherine, who got married. I want to say it's a couple of years ago. And I think they're both advocates to the National Down Syndrome Congress as well, self-advocates. So they give talks and they travel. Just thinking about something like sexuality, it's not something that gets brought up, but I think it's something that's in the back of everyone's mind. So I just want to get you familiar with some things that are unique or not so unique. Now, boys and girls who have Down syndrome actually achieve puberty about the same time as their peers. Women are able to get pregnant, and there's a 1 in 2 chance of women having for a woman to have a child with Down syndrome. Now, men actually have a decreased chance of fathering children, but everybody tends to mature about the same time. I think as parents, what's important to remember is to really give your child guidance and to teach them what physical affection is important for each age. It's hard because you have teenagers who really want to be affectionate with everybody. I don't know, we used to do like these little parents' nights out, and we had older kids who have other genetic syndromes who are very, very affectionate. And sometimes it's really important to sort of take that child aside and say, okay, listen, you know, it's okay if you hug mommy, or it's okay if you hug aunt so-and-so, but probably not okay to hug a lady you don't know as well. And it's really important to help kids maintain society standards for privacy or modesty, and really sort of teach kids to be empowered and protect themselves. And then it's really important that you guide kids to not show affection in a way that's not necessarily acceptable. We had one teenage girl that came to clinic, and she came and she gave me a hug, and we had a male resident with us, and I just kind of said, oh, aren't you going to give Dr. So-and-so a hug? And her mom was quick and said, no, she does not hug men, but she can shake hands. And so it's really important that you kind of get those ingrained in your children. And she didn't actually get anywhere near him. She did shake his hand. And it's really important to teach kids the difference between what is acceptable in the privacy of your own home and what's acceptable in public, because sometimes that awareness just isn't there. You don't want to say no. You don't want to freak out, even though it's really hard. You want to be as calm as possible and really respect your child's autonomy and individuality. Now, when we talk about, you know, sexual activity and sexuality, I think what's important for individuals who have special needs is really thinking about their awareness and protecting themselves. So I just found a few rules for adults in regards to legal consent to sexual activity. So as an adult, really it's legal if they're aware of where they are, who they're with, and sort of what time is happening at that moment. It's really important that young adults have a basic knowledge of sexual activity, and I think they do a pretty nice job of addressing this in the public schools. They really should know that you can get pregnant and that there are various diseases out there that you can get as well. Kids also need to know that no means stop. Now, I think sometimes, and it's very normal for kids to experiment. I think we think back to our childhood, we think about the movies that we probably watched when we were younger and our parents were asleep or something. And it's really, really important to because kids get exposed to a lot of different things, and they tend to kind of test limits. They test limits with authority figures, and they test limits with their friends. So it's really important that you teach your kids some sense of boundary. And it's okay for kids to sort of be in a romantic setting. I mentioned High School Musical. I think High School Musical is some sort of cult that's brainwashing all the kids, and I think that's kind of put this sort of romanticization in everybody's mind. So it's really, really important that kids sort of know what is okay. And also, kids need to be confident, and they need to be confident and empowered so that they are not mistreated by other people. Because unfortunately, and just not to scare people, but unfortunately there are those people out there ready to take advantage. And also, for kids who are a little bit higher functioning, it's important that they understand not to be very overly aggressive with children who aren't functioning as highly. Usually when kids are about the level of an 8-year-old is when they can start to distinguish a little bit between what's real and what's not real. So it's really, really important. You know, a lot of times kids have crushes on teachers, or they have crushes on other adults, and, oh, this is my boyfriend or something, and it's really, really important. You know, that's cute and that's funny for a while, but it can be a little bit of an issue if it gets out of hand. So it's really, really important that you educate your child as they get older with that. And as I mentioned before, children have to have some awareness, so they have to be able to develop their own sense of value. And they have to be able to reason through a situation and also use their own judgment to make decisions when they're put in these situations. Because we want our kids to be exposed as much as possible to what's out there. We want them to go to dances, we want them to go to parties, and we want them to be involved. but it's really, really important that they are empowered when they are in these situations. And also, they should be able to recognize how another person is feeling or what another person is thinking a little bit too. And I think from my experience, a lot of kids are pretty aware of that, and they show a very good sense of empathy. The most important thing, and we talked about empowering and autonomy and individuality, is that we teach our kids that they have the right to refuse, and we teach them how to do so in an appropriate way. And we also need to teach them who the trustworthy adults are in their lives that they can go to. So basically, just to reiterate what I just mentioned, it's really important that kids are empowered to say no and know who to go to report anything that makes them uncomfortable. And also, they should know activities that are high risk. So if they are being hurt in any way or harmed in any way, they should be able to say no and know who to tell about it afterwards. Now, again, we'll be available for questions. This is so in summary, we talked a little bit about behavior and and what's acceptable. I think the most important things to think about is we have to remember that sometimes our kids may not be functioning as old as they are. So we have to take that into consideration when looking at behavior and not really diagnose everything as a problem. And secondly, as our kids get older, we need to teach them to be empowered and to protect themselves and to be able to know who to go to if they feel uncomfortable. And then I wanted to give my gratitude to our clinic team. We actually have a Monday team and a Tuesday team. So from that way to that way, we have from the top we have Lindsay Jones and Meredith Ford, our physical therapists. We have Kim Wright and Andrea Gartman, our occupational therapists. As we go down, we have Lauren Neff and April Brackett, our speech pathologists. We have Brigitte Mueller, our volunteer, who is here with us this evening. And next to me is Carmen Dickerson, who is our social worker. So we will answer questions later. I will hand the mic over to Rosa Rocha, who has been very instrumental in helping us get the clinic where it is today.